Hello. Today we will talk about Olecranon fractures. So let's talk directly. Epidemiology. Bimodal distribution is seen with younger individuals as a result of high energy trauma and older individuals as a result of a simple fall. For the anatomy, the coronoid process delineates the distal border of the greater sigmoid notch of the ulna which articulate with the trochlea. This articulation allows motion only about flexion and extension axis, thus providing intrinsic stability to the elbow joints. The articular cartilage surface is interrupted by a transverse ridge known as the bear area. Posteriorly, the triceps tendon envelops the articular capsule before it inserts onto the olecranon. A fracture of the olecranon with displacement represents a functional disruption of the triceps mechanism, resulting of loss of active extension of the elbow. The ossification center of the olecranon appears at 10 days and is fused about age of 16. There can be persistent epiphyseal plate in adults. There are usually bilateral and demonstrate familial inheritance. So for this point, you can make another X-ray for the other side and compare. The subcutaneous position of the olecranon make it vulnerable to direct trauma. Let's talk about the mechanism of injury. Two common mechanisms are seen, each resulting in predictable fracture pattern. First, direct, a fall on a point of the elbow or direct trauma to the olecranon typically results in comminuted olecranon fracture. Indirect, like the fall on the outstretched upper extremity, accompanied by strong sudden contraction of the triceps, typically result in transverse or oblique fracture. A combination of these may produce displaced comminuted fracture or, in case of extreme violence, fracture dislocation with anterior displacement of the distal ulnar fragment and radial head. For clinical evaluation, patient typically present with the upper extremity supported by the contralateral hand, while the elbow is relatively in flexion. Abrasions over the olecranon or hand have been indication of the mechanism of injury. Physal examination may be demonstrated palpable defect on the fracture side, and inability to extend the elbow actively against gravity indicates discontinuity of the triceps mechanism. Careful neurovascular evaluation should be performed because associated ulnar nerve injury is possible, the ulnar nerve, especially with comminuted fracture resulting from a high energy injuries. Radiographic evaluation. Standard anteroposterior and lateral radiographs of the elbow should be obtained. A true lateral radiograph is important because this will demonstrate the extent of the fracture, the degree of comminution, the degree of articular surface involvement, and displacement of the radial head if present. The anteroposterior view should be evaluated to exclude associated fractures or dislocations. The distal humerus may obscure osseous details of the olecranon fractures. Classification is called Mayo classification. Mayo. The distinguished three factors that have direct influence on treatment: fracture displacement, comminution, and ulnohumeral stability. So, for type 1 fracture, they have 1B, 2B, 2AB, 3AB. For type 1 fracture, non-displaced or minimal displaced and are subclassified to either non-comminuted 1A or comminuted 1B. And the treatment here is non-operative. For type 2 fractures, have displacement of the proximal fragment without elbow instability. This fracture requires operative treatment, which has two types. 2A fracture are non-comminuted, can be treated by tension band wire fixation, and type 2B fractures are comminuted and require blade fixations. Type 3 fracture features instability of the ulnohumeral joint and required surgical treatment. Also, there is a Shasker classification, but we will not about it. Treatment options. What is the objective of the treatment for the olecranon fracture? First, restoration of the articular surface, restoration of and preservation of the elbow extensor mechanism, restoration of elbow motion, and the prevention of stiffness and prevention of complications. Non-operative treatment. indication for non-displaced fracture and displaced fracture in poorly functioning older individuals. Immobilization in a long arm cast with the elbow in 45 to 90 degree of flexion is favored by many others, although in reliable patient, posterior splint or orthosis with gradual initiation of range of motion after 5 to 7 days may be used. Follow-up radiograph should be obtained within 5 to 7 days after treatment to rule out fracture displacement. Osseous union is usually not complete until 6 to 8 weeks. In general, there is adequate fracture stability at 3 weeks to remove the cast and to allow protected range of motion exercise, avoiding flexion past 90 degrees. Okay, no flexion more than 90 degrees. For operative treatment, what's the indication? Disruption of extensor mechanism, which means any displaced fracture. Second, articular incongruity. Types of operative treatment, what's the option you can use? First, intramedullary fixation, like this. It's called intramedullary fixation. This is 6.5 mm cancellous lag screw fixation. The screw must be sufficient length to engage the distal intramedullary canal for adequate fixation. This may be used in conjunction with tension and wiring. With screw technique, beware of pawing of the ulnar intramedullary canal that may shift the fracture with screw advancement. Next, tension band wire in combination with two parallel Kirchner wire. This counteracts the tension force and converts them to compressive force and indicated for a valse type of the Olecranon. For the valse type, you will use 2K wires and two tension band. The tension band aim here is to convert the tensile force to compressive force. Next, plate and screws. They are used for comminuted olecranon fracture, Montague fracture, olecranon fracture dislocations. A blade should also be for oblique fracture and for fracture that extend distally to the coronoid. No mechanical difference exists between posterior or lateral placement. Fewer problems with blade prominence are noted when it placed laterally. So laterally, it means prominence. Excision of the olecranon with repair of the triceps tendon. This is indicated for non-united fracture, extensively comminuted fractures. So this is your end way to fix this problem. Some people or some authors that excision of as much as 50% of the olecranon is effective in treating a comminuted fracture. So you can remove as much as 50%. Mori demonstrate decreasing elbow stability with increasingly large fragment excision, decreasing elbow stability. This is contraindicated in fracture dislocation of the elbow or fracture of the radial head because excision results in compromised elbow stability. So if someone have fracture of the radial head or fracture dislocation of the elbow, you cannot make osteotomy for the olecranon. Post-operative management, the patient should be placed on a posterior elbow splint with a stable repair. One should initiate early range of motion exercise. For the timing here, it's important to the range of motion of elbow always 1 week and posterior splint for around 6 weeks. Complications. This is example of the plate. Complication hardware symptoms occur in 22 to 80% of patients. From 34 to 66 require hardware removal. Hardware failure occur in 1% to 5%. Infection around 6%. Pain migration in 15%. Ulnar nutrient and ulnar neuritis occur in 22% to 12%. Heterotropic ossification, non-union, decrease range of motion. This may complicate up to 50% of cases, particularly loss of elbow extension, although most patients note little if any functional limitation. And that's it for Olecranon. Thank you.